Hello and welcome to all for this session on equity, diversity, and inclusion, discussing the testimonials on terrain, where we will be able to analyze the application of our learnings on anti-oppression applications and the approaches based on our activation of care taking. I am Tanya McDonald, and I'm Director of Initiatives and Strategic Work for Care Canada. I am your animator for today. Before we begin, please note that certain tools will allow you to fully appreciate the webinar. We are happy to present today's session in French with simultaneous interpretation in 3 languages. If you wish to hear the voice of our interpreter in English, please choose English in the interpretation menu at the bottom of the screen. The interpretation in American language signs or Quebec language signs is also available. You can access this by clicking on the interpretation button in your Zoom menu, which is located at the bottom of your screen. We also ask you to click on the menu options, viewing options at the top of the slides to choose the language in which you wish to see the slides during the presentation. This session is a space for learning and reflection. Please note that we have put to your availability support resources in French and in English, which will allow you to discuss the content which is discussed and to offer your well-being for everybody today. You have a consultation service available throughout this session and during the 3 hours following at the phone number which is written in the chat. If this service is heavily used, we'll ask you to leave a voice message and we will call you on a private number. You will notice that the chat room allows all the participants to discuss with our panelists only. It doesn't allow discussions between participants. We assure you that your comments and reflections are welcome at all times, and our team is working in the corridors to ensure that the key messages are transmitted to the entirety of the public. As we have a very full program with our panelists, we won't have time to touch on your questions directly today. However, we will collect your questions and comments and we will transmit your responses, after the webinar. Finally, please note that the session will be recorded and that the recording will be sent by email and placed on the website of Excellence Canada in the upcoming days. We thank you for taking the time to join us today. We will all learn together with an exceptional panel of panelists, of speakers. If you haven't done so yet, please respond to our survey questions, which appears on your screen. To see the question, please go down on the frame and transmit your answers to us. I'd also like to highlight that we're all joined together online today from several sites in the country. I recognize with gratitude that I join you from the territory, the unceded territory of the Algonquin people in this city, which is now known as Ottawa. I'm privileged to live on this rich territory, surrounded by nature, and particularly the Ottawa River, of which I take full advantage of. Please take a moment to think of the territory on which you find yourselves today. If you don't know either your residential territory or its history, we've added to the chat a connection to Native Land Digital. Next slide. So it's with pleasure that I introduce the speakers for today's session and the animator for the session of today, Audrey L'Espérance. Audrey is an assistant professor in health and social services in management at École nationale d'administration publique in Montreal. She holds a doctorate in political science at the University of Ottawa and did a postdoctoral fellowship at the University of Toronto. Her work focuses on patient and public partnership in the health ecosystem, as well as the mobilization and integration of experiential knowledge and expertise in policy-making processes in the health sector. Assistant Professor of Health and Social Services Management, École Nationale d'Administration Publique, ENAP. She has been a support and advisor on the development of the Equity, Diversity and Inclusion Learning Exchange. Welcome, Audrey. Thank you, Tanya. Thank you for your welcome. The exchange of virtual knowledge on equity, diversity, and inclusion was conceived in part with a consulting group with Denise McQuaig and Carol Fanquat, which unites several different players from the healthcare system throughout the Pan-Canadian system for health and social services. The recommendations and opinions were useful for the elaboration of virtual context and allowed us to create pertinent resources for safe usage for the participants. As a former group of the consulting committee, it is my pleasure to be the animator today and to present the 4 panelists to you. During the last webinar, which took place last year, we discussed the medal for discussing the unconscious privileges and treatments in order to improve treatment of inclusion, social inclusion. Given the individual and systemic traumas, this was presented by Excellence in Health Canada. The recordings of these sessions can be found on the website for Excellence in Health Canada. I would like to thank the members of the consulting group for their recommendations and their commitment to develop content which allows us to reflect and eventually act differently. Next slide. It is with pleasure that I present the speakers for the session today. We will hear 2 case studies, one from Doctors of the World Canada and one from Care Communities. I will present our speakers, Ghislaine Rouly, living with 2 orphan genetic diseases, surviving 3 major cancers. Ghislaine Rouly has been in the healthcare field since her birth. She is active in accompaniment services for the last over 50 years and is a member of the governance committee at the CHUM's Medical Aid in Dying Committee in 2015. At the Faculty of Medicine at University of Montreal, she's been participating since 2012 in mentoring activities and 3 CSS courses on collaborative practices. Ghislaine also acts as a patient partner at the Centre of Excellence on Partnership with Patient and Public, CEPPP, since for the last 7 years, and she is co-president of the Strategic Council. Ghislaine co-founded the participative research program for Care Communities on the integration of peers in community services, a program that they will present to us today. Antoine Boivin is a practicing physician and the Canadian Research Chair in Partnership with Patients and Communities. Working as a family physician in the community of Centre-South Montreal, he completed his master's and doctorate in health services research in the United Kingdom and the Netherlands. Over the last 15 years, his research program has focused on patient and citizen engagement in community care, health services delivery, and science and policy. Co-founder and scientific director of the Centre of Excellence for Partnership with Patients and the Public, one of the largest organizations dedicated to partnership science and practice in Canada, he is also co-director of the Quebec SPOR Support Unit. Pénélope Boudreau is a director of national operations of Doctors of the World. She has walked the streets of Montreal since 2006 to offer care to people in situations of homelessness, collaborating with different community organizations. She's also contributed to the organization of a medical clinic for people with precarious status, and also developed a project for indigenous navigators within the team of Doctors of the World. Finally, Farron Shore is a trans and gay activist since the 1970s. He's focused on a non-binary approach to human relations and gender presentation. After 30 years in the fashion industry and having survived AIDS, he made the decision to go back to his roots and pursue a career as a community peer worker. Mr. Shore currently works as head of the peer project at Doctors of the World. I welcome the four of you. Thank you very much for being with us. Please allow me to begin by asking you if you could share a little bit more about yourselves as individuals, as teams, but particularly with the way in which you take care together. I will offer the microphone to Farron, perhaps, to begin. Hello, Farron. Hello. Could you repeat, please, the question? I didn't hear it well. Of course. I wondered if you would like to tell us a bit about yourself as an individual, but also as a team, the way in which you care together, you and Penelope. Okay. I think I will begin with what is most common, and that is our humanist approach toward our patients and our work. It is something that is really unique in this team in which I work with the Doctors of the World. We have a respect for the individuals and for the limits and capacities of the individuals with whom we're working, which is out of the ordinary, extraordinary. We always put the individual forward. This is our first consideration when we work with people. It is something that is not necessarily very visible for the people around, but in the helping relations, this relationship of confidence and commitment, personal commitment to the patient is really the key to offer an accompaniment or support which is of quality and which is really collaborative to improve the life quality of the individual, or the quality of life of the individual. Very much so. Thank you. Penelope, would you like to share a bit how you and Farron work together, in what context? Well, hello to everybody. In fact, I began working at Doctors of the World as a close nurse with a backpack in the street in 2006. We always thought that the healthcare, the people who needed most of the care, or those who regularly experience barriers to healthcare, were not necessarily well reached by the healthcare community in the hospitals, the medical clinics. And so we did close work in collaboration with community organizations in Montreal, going where the individuals are, where they consume, where they work in their spaces of socialization. And we went with street workers. For the last 4 years, a bit more than 4 years, we have the opportunity to work now with in First Nations navigators, peers in prevention of overdose, peers who have experience of migrational experience. So individuals like Farron who have experience, knowledge of healthcare, which is much larger than what we, the healthcare workers with diplomas and a very medical vision of healthcare, treatment that is very medication-oriented, the arrival and the collaboration with the peers, and definitely collaboration with Farron over the last 2 years has allowed the team of nurses, social care workers, volunteer doctors to open up, expand our vision of healthcare, and in this way better respond, better understand, offer a space which was more welcoming, and better responded to the needs of the individuals that we see, who are both people experiencing homelessness, people who consume drugs, people who are sex workers, First Nations individuals in urban situations, or migrant individuals with precarious status who don't have access to care. So our team is multidisciplinary, but not as we hear it in healthcare environments at the hospital with big titles and individuals who have an academic pathway which is unbelievable. Our pathway is experiential. Our experience has brought us finesse, a better understanding of the realities of the individuals that we wish to accompany and support in their taking charge of their health and their pathway through their health, which is much larger, and I repeat myself, than treatment and medication. May I allow myself, perhaps, Farron, when you were speaking of putting the individual in the center, how do we do this when we collaborate with individuals, as Penelope said, who are in an environment with a vision that is perhaps different than that which you carry? Is it difficult to conjugate, or does this collaboration become installed in your work of day-to-day work on the terrain? I would say that at Doctors of the World, I find that, in fact, the healthcare workers are very much on the same page of putting the individual in the center of the healthcare. But in the past, I had worked with other organizations where it was much more difficult, where there was much more of a struggle on my behalf and on my peer colleagues to really convince the professionals, the healthcare professionals, to put the individuals at the center of their care. And for me, it is a great privilege to work with a team where it is already established this type of work with the individuals. Thank you. I wanted to hear about your experience, Antoine and Ghislaine. Perhaps Antoine first. What is a community of caretakers? To put you into context, I work in an ordinary clinic of general practitioners in Montreal. We are quite a large team, almost 50 professionals, health professionals, doctors, nurses, social workers, psychologists. We're in a neighborhood in Montreal where there are big social inequalities, a lot of homelessness, drug consumption, single-family households, seniors living alone. In theory, the clinic is open to all, but in reality, 25% of the members of our community don't have access to the clinic and are not registered with a general practitioner. Why? Ghislaine and I work together. We've been working together. We met in 2015, Ghislaine and I. As a doctor, I often had the feeling of being the good solution to a bad problem. The people who came to my office often have medical symptoms, whether it's fatigue, anxiety, depression, pain. But the problem underneath is often social. It's a problem of poverty, isolation, family difficulties, professional, immigration, loss of identity. There's an illness. And these are not things that can be taken care of with medication, with the little pills. When I met Ghislaine in 2015, I had the impression that I was meeting a sister, as if we were two caretakers with a pathway and strengths that are complementary. Ghislaine knows things that I don't know, And in the beginning, I didn't really know how she worked, but I was confident that in working together, we would be able to be better caretakers. What we meet, Ghislaine and I, often is that our work is to create a chain of confidence. When I present Ghislaine to some of my patients, I say I would like to present them to somebody in whom I have confidence, who might be able to accompany them in their challenges that they're living. And we support each other in a complementary manner. We listen. I listen to offer diagnoses. Ghislaine listens to get to know the person. I take care by intervention. Ghislaine takes care by through accompaniment. Initially, the caretaker community was a pilot project. We were working as peers with Ghislaine to integrate in community care. Following this, it was formalized with a participative research program, which was co-founded by Ghislaine and I. And now, Ghislaine's work is more and more recognized by some of my peers at the clinic who refer me to patients also, but also in terms of research, namely through the recognition of Ghislaine as co-director at the Research Chair of Canada, and more recently, we have built connections with other teams, such as Farron and Panelist's team, who work similarly to us, who have shared values, and we look to see how we can work together. That's it. Thank you. Ghislaine, can you tell us a bit more about your role when you work with Antoine? How do you complete one another? Antoine was saying that you complete each other well. Well, hello, good day to everybody, first of all. From my early childhood, I've been in hospitals, of course, but very naturally, I simply want to explain my pathway so that we can understand a little better. Very naturally, I took the habit of training the patients who were with me in a room. It's not always the case to have private rooms, and I realized quickly the impact that my actions had on their well-being. Having come close to death myself 3 times, and later having accompanied my daughter who was suffering from cystic fibrosis and who passed away in her 20s, I quickly became interested in end-of-life care, accompanying people in their end of life. I followed several trainings on grieving, death, palliative care, and decided to specialize in end-of-life accompaniment. In 2015, with the arrival, I was also asked to accompany people who asked for medical end-of-life. And when I met Antoine at about the same time, there was a change that took place. First of all, we worked together at the clinic. We created and founded together the caretaking community, as Antoine explained. And then, if you like, with more than my 50 years of experience accompanying, my interests broadened in a certain manner to not only accompany towards death, but rather towards life, care. So Antoine takes care, if you like, with medication, etc., the body and everything. And for myself, if you like, I'm more interested in finding a solution. What is not going well? Why, for instance, as a patient that Antoine will care, he will follow over years, there's something that he isn't managing to discover. And my role is a little bit to be the Inspector Clouseau, if you like, and to detect what is missing, why. And so that's all. And so Antoine is mostly the care, the physical, and for me it's to recognize the individual in all of their globality, their wholeness, if you like. And what takes place is that we really work harmoniously and complementarily. I don't know if I've properly responded to the question, but that's it, yes. Definitely. Farron, I'd like to come back to you because I imagine that there are similarities also with Ghislaine, a pathway that helps us to enter in contact with the people. Can you tell us a bit more about this? Yes. It's a little different for me in this sense that I don't have the background of caretaking within the system, the health system. that Ghislaine has. My beginning in this domain was when I was an adolescent in the street and I sought out help in my environment. This was the beginning for me. And that is an effort which was very different from what we see in the healthcare system. When you're a member of a gang, of a youth gang in the streets, the combination is really different. Accompaniment is really different. It's really organic. It's really intimate. It's long term. This means that interventions will take hours. They can take days, weeks to find necessary resources. So it's really different from what I met within the healthcare system. And this aspect, which is to care for the person in their globality, in their wholeness, I find this is what is lacking in our system, which I cannot replicate within the healthcare system, given the framework, the working framework. It's not possible to remain 6 hours with a patient when they need that. So, yes, there is a similarity in our experiences, but there are also things that differentiate Ghislaine's experiences from my experiences. Thank you. I was wondering, Penelope, perhaps even Farron, you can complete. What does it bring when you go towards people together with your two perspectives? The intervention what does it win? What do you gain through this collaboration by intervening as two or several? I'd like to say that the great bonus is, first of all, for the team, because these moments of exchange where we share together, we have team meetings together, we learn from the perspectives, we challenge our own perspectives, our own ways of seeing. So the first great strength of this team is all our knowledge, our competencies, our experiences which are different. And so we transform and become ourselves better workers. And so we open, it's a reflective work where we put ourselves back into question what we have learned and how to do things. Farron talks about 6 hours with an individual. I did my nursing course, 45 minutes. We stand up, we put our hand on the door handle to indicate to the person that it's ending now and that they're going to leave and that they've made enough requests. And then, whoops, I have somebody in front of me and that person says, oh, I would spend 6 hours, I would spend a day. We bring back into perspective what we learned, what we've worked from the beginning, and we ask, and I hope, and for our team it's this, we ask the good questions. We learn very academically, but the individuals don't fit into such restrictive molds, and definitely the people with whom we are intervening don't want to refuse those words. They don't enter into those molds. So how can we do things differently? How can we be different? And I would like to say that in the environment, when we're with these people, it's an exchange when it's possible. And it's also more we collaborate together, more it becomes fluid, where we understand the person with whom we're intervening is choosing, can feel more comfortable discussing certain things with one of the team members or another member. So we no longer have titles, oh, it should be the nurse or it should be the doctor. It's something that becomes really fluid. And more we work closely together, more we become colleagues, more we trust one another, the intervention is just improved. And the people that we meet and we accompany have the choice. And they also see individuals who have more openness, no matter what the title is behind. I was wondering, yes, go ahead, Farron. But to right on what Penelope is saying. I think that this element of exchange, of having two individuals before the patient who have different perspectives and who can dialogue about this, leaves this space to the patient also to enter into the conversation in the preparation, in the decision-making process with the workers. It's not easy to face professional healthcare workers who are themselves in a diversity of perspectives and who leave this space to the patient, to their own perspective and their own opinions and words on the situation. So it flattens a little bit the power rapports, you would say, Farron? Yes. Yes. I think definitely one of the things that is really particular in this type of situation is the commitment of the patient. It's less being taken in charge than an empowerment where the individual has their own power within the decision-making process. Antoine, Ghislaine, does this echo with your way of working? Absolutely. I know that working with Ghislaine transformed me a lot as a doctor, but also as a human being. At the medical school, we learn that the doctor knows things, that he is strong, that he takes in charge the patients, and that the patients are vulnerable. And further, in family medicine, we are taught that we are the front line, the first caretakers. As I work with Ghislaine, I learned that I'm not the first caretaker. The first caretaker is the individual themselves, that they have strengths, that they have objectives, that they have knowledge, which is beginning to mobilize even before they present themselves in my office. They take care of them. They're making the decisions to come and consult me after perhaps having consulted internet, friends, neighbors, and who've done all sorts of other work towards their situation than me. And working with Ghislaine also teaches me or reteaches me that I am also being taken care of. I also have my uncertainties, my vulnerabilities, my moments where I don't feel so strong. And our work as colleagues between Ghislaine and I sometimes is I go and ask for counsel from Ghislaine and her support when we experience difficult situations. Let's say when we're taking care of a patient together. I remember a few years ago, a patient who passed away. I was in distress, and Ghislaine comforted me and helped me to put things back into perspective and reminded me of, not of all the things that I didn't do for the patient, but all the things that I had done for her. So this helped me in my grieving as a caretaker. So there's really, when I say a complementarity of the roles, we're two caretakers and we're two being taken care of who are working together. Ghislaine, you would like to share? Yes, of course. I never really wanted to take on this idea that we're vulnerable people, that we're fragile, that we need to be saved, taken in charge of, etc. I never considered myself either as a victim, no matter what happens in life, whether it be illness or anything else. I have my words to say, my opinions. I have choices to make, decisions to make, and this belongs to me. And in fact, I've always being a partner of my own cares, and later I became almost an official patient. If you like, it's to put our knowledge together, our scientific knowledge, our experiential knowledge of life with illness, but not just this, all my knowledge, others' knowledge. We're not just patients, we're citizens. And what makes the strength of our team, Antoine's and mine, I would say, and also for Penelope and Farron, is to recognize that sometimes roles are inversed. or reversed, and to also take and recognize the values. We have the same values in our way, if you like, of approaching the patients with much humility and humanity. I think this is where we meet the two teams. First of all, it's in this patience we have of the other, of the human being that's suffering. The patients also, we have values that meet in the two teams. Humility also, we don't take ourselves for a doctor. I don't take myself for a doctor. Antoine doesn't take himself for a president or something like that. We have this humility of recognizing our limits also, but to recognize also all the values that we have and the knowledge that we have, and that we can contribute. If we have the two teams together, we're really facing miracles. I'm certain of this, at least. I was wondering, while listening to you, perhaps Penelope and Farron, can you speak to us of a typical day? What does it look like working together for you? Is there a typical day? I have the impression that there aren't any. But I think it's the same question that I would ask also Antoine and Ghislaine, perhaps Farron and Penelope, first of all. Oh, it's really difficult to respond to this. There's really not any typical day for us. I imagine that the work that we do on the terrain is perhaps another departure point, because everything that goes in through the meetings, committees, it doesn't touch the patients directly. But when we're in the street, or with the mobile clinic, rather, the typical day is it's to find again the way to create connections with the people. And so there's a lot of to have a sense of the environment, how the individual positions themselves in the environment, how the individual reacts with different things, not to have an idea of what approach I would like to take. We use things like sampling, testing, distributing materials for consumption as a tool to engage the individuals, but it's not our only tool, and it's not necessarily the medical care which is priority, because from a more holistic perspective, it's also the relationship with the individual, with who they are, which is primordial when we are working on the terrain with an individual who is marginalized. So this idea of creating connections of confidence is really our first goal when we're on the terrain, and to reassure the individuals, to validate who they are, what they want to express, and to ensure that they are well supported by our team. So following this contact, there is referencing, there are other things to do, but that is really the key, because it's really a situation where we say that health is really angled toward the individual and the dynamic between the individual and their environment, their surroundings, their family. So we're angled towards the environment and the dynamic of how this person exists in their environment. I have the impression that it goes through the relationship first and before anything else, unless I'm mistaken, through the relationship, and as we were speaking earlier, through the person who is at the center. If we go and meet the individuals where they are, we can't have a typical day, because the terrain is always different. The beginning of the month, the end of the month, the passing by of the police, the drugs which were contaminated, death in the community. Everything has an impact on the individuals, the reality, how they receive us, how they will welcome us, what their vision is of their health or their presence today in that moment, which is present, because the individuals that we are meeting really are living really in the present moment. They have to eat, they have to find lodging, they have people around them who aren't going well. So we rarely project. Farron, I have quotes from Farron regularly in my mind. A life is a day is a life, tomorrow will be another life. So we think about today. So our work, the team's work, is to adapt to this, to arrive without any expectations. We arrive and we welcome the individuals in their present moment with where they wish to go. In my own work, I'm more on the terrain. Unfortunately, my patients, as the team of Doctors Without Frontiers, we have a team of about 20 individuals, and it's also the team which arrives with all of what is taking place on the terrain and the personal life, which mixes in with professional life, the impact of the colleagues, the experience in terms of work, the individuals that we accompany. I think that what meets all of us, all the people in the teams of Doctors of the World, is the fact that there is no routine. We're there and we adapt ourselves, and that's what keeps us alive and motivated. Unfortunately, we have wanted from the beginning that Doctors of the World disappear. It's not normal to offer care outside of the healthcare system in Quebec, in Canada. There are hospitals. We must notice that there are people who, notwithstanding the hospitals, don't have access. And that's why we exist. There's great injustice. But to fight this is an engine to continue. And it's something that brings us together. Ghislaine, I was wondering, is there a typical day for you in your team, Antoine and you? Not really. Not really, because it's a work based on relationship. And besides, as Farron spoke, the meetings, the committees, etc., a typical day that I call a clinical day, let's say, there is none. And the individual, I have numerous patients that I accompany, and each one arrives with their source of distress. People are very sick, etc. So there's never a routine. It's never the same. There are a lot of mental health problems. Antoine takes care of the physical. I take more care of the other side, social, mental, etc. To try and give back some hope to these individuals who've lost everything. For some, illness is, and most of them suffer from chronic illness. We're not talking about healing. It's not a step. Okay, we've got through it and it's over. That's not it. And there's age and all the conditions. Most of the patients that I accompany are individuals who live in a precarity. They're not in the street, but they're almost there. But sometimes I tell myself they would be better off in the street. It's horrible to say, but sometimes it's like this, because at least in the street, they're Doctors of the World, they're organizations, etc. It's not a solution. That's not what I mean. But it's to this point where there are things, there's injustice also, which means that each day the clinic is an experience in itself. It's unique. And this, we must, at least I must prepare myself psychologically to welcome the distress of the other without being too affected. But of course, there are things that remain that have an impact, and it bounces back too. It's not something that we must take lightly, I'm not there either to take the place of anybody. I'm not a psychologist. I'm not a professional, healthcare professional. I'm not a social worker. I'm an accompanying peer who followed trainings, who has numerous years of experience. But at the same time, if you like, we have something. The work that I do is work that is natural, that we have been doing since the world exists, helping. And our citizens, our indigenous citizens with the elders, it's a little bit the role. And seeing the age that I have, it's a bit of a role of grandmother, cocooning, all of this. No, there's no typical day. Antoine. Well, our guide in our work for Ghislaine and I think it meets a lot the philosophy of care of Farron and Penelope, is accompanying the individual in his life objectives or her life objectives in their own rhythm. And life objectives are not necessarily objectives for in 20 years. It might be objectives for today or for next week. And sometimes these life objectives, even if they are expressed in a healthcare environment, have nothing to do with medical care. Often it might be somebody who is in my office who had a cancer, incurable cancer diagnosis, and their objective is to get back in contact with their family who they haven't spoken with in 30 years, or to create a garden for the summer, or to create the space to accompany individuals in this pathway. And we are asked to create other ways of caretaking, which are not usual in the healthcare environment or system. Our way of advancing from the beginning is to tell ourselves that if it's not banned, then we can do it. So we advance carefully, one step at a time. We gain confidence progressively from our colleagues amongst the people with whom we're working. This has been long-term work. Just to have the idea accepted that Ghislaine is working within the clinic was not obvious at all. In the beginning, everybody was afraid of this. But progressively, through time, there has been a confidence that has been built, and we have slowly built alliances which have allowed us to be stronger and stronger. One of the opportunities that we had in our clinic was the integration of Ghislaine within the weekly team meetings of the caretakers to discuss the situations completely. This allowed the team to get used to Ghislaine's role, to understand all the strength of her expertise, to what point her perspective was complementary in helping the team to resolve difficult situations or complex situations. This was a great opportunity. The other opportunity was to make alliances with other caretakers teams, which also work with peers so that we can support one another. For instance, we accompanied, Ghislaine and I, the team from the clinic It's Homelessness in our neighborhood with a life experience of the team during the pandemic. So we were helping the clinic in their startup. We said, we can help you, we can accompany for recruiting and for training. Now it's those people from the team who are helping us. They managed to formalize the role of Danielle, and they can also help us in the clinic. Same thing with the team from Doctors of the World, who are very advanced in their integration of peers. So we each have our strength. We have a research team, so we can bring this aspect. The team from Doctors of the World all have a diversity of peers with migration experience, indigenous experience. And recently, Ghislaine created a circle of peers where we meet several times a year to learn amongst peers, but also amongst professionals working with the peers. This allows us to create a larger team which can advance altogether. Thank you. I was wondering, because earlier I was listening to Penelope and Antoine on the fact that it requires of you as healthcare professionals to change perspectives, to adapt your role. I wondered if it's the same thing for you, Ghislaine and Farron, if It seems to be natural. Is it so much? Is there something that brought you to be in this mutual support? Perhaps to begin with, Farron, if you would like to. Is it natural to do this work for you? And it's like yes and no. Like, as we heard, it's human nature to help others in our community or in our environment, our surroundings. And it's something that I did when I was a youth in the streets. I did it easily. For me, it's less obvious to create peers within the healthcare system, given that the perspectives are so different. But I am a type that likes challenge in my life, so I'm ready to do the work that is necessary so that we can have this success, because I really feel that for the people, particularly who are disaffiliated or marginalized, to see that somebody else who has come out of the same environment can have a good relationship with the workers in the healthcare system, this is key. It is really important that this confidence be present in the moment that the individual wants to advance. And as the marginalized people, the fact of suffering another rejection is really horrible. It's really, this is what makes the individual so apt, so difficult to connect with. And this is what is one of the major barriers to bring the people into the healthcare system. So the moment that I do my work well and that I'm able to create help or mutual support positioned in the system, then we're win-win for the patients and for ourselves who are working as peers. Ghislaine, is it the confidence chain of which you were speaking earlier? We could say that for myself, of course, there is, first of all, a chain of confidence, but as Farron says, we can't go against the other. The other must be ready to be accompanied, ready to want to make an effort. Also, all the changes, I'm not the one who makes them. I'm there to accompany. But if the individual is not ready and doesn't want it, my role will be to be there, present, to listen, but there won't be any transformation. There won't be any change. I think that for myself, at least, it's something that is natural. No matter where I am, I can be sitting in an airplane and automatically if somebody will tell me their life. I don't know why, but that's how it is. So it becomes really natural. And what I would have liked to have said also was that the work that we do with Farron, even if it's different, somewhere in the foundationally, not only did we survive, both of us, we learned resilience, but through our values, our actions, our humility, our great love for others. But I think that especially our tragedies and our traumas are inexhaustible resources which are there to help ourselves and help those that we're accompanying. And so I think it's all our experiences, the fact of not victimizing ourselves, to say, oh, Farron went through difficult experiences, myself also, but we use those experiences to help the other. And I think that that is something natural. We have that or we don't have it. I always say we have it or we don't have it. That's it. In the 2 minutes left, I would like to ask you, what teaching would you like to pass on to the people who have the same professional role or as patients, users, peers as you, Ghislaine, Farron, Penelope, and Antoine? I think if we had to pass on to the next, what would be the message that you would give to somebody who has a professional role or personal role as yours? Penelope, perhaps first? My advice also answers the question which was addressed to Ghislaine and Farron. We're there. Everything is wonderful. It's beautiful to work together. It's not always beautiful. Sometimes we struggle. I think the confidence relationship that we have managed to establish between ourselves and the great respect of the pathway of the other means that we're able, sometimes Farron goes in a direction, and for me, I would have a different idea. I know that Farron, sometimes he hears things and he finds it too medical. No, we have to open more. So the fact that we trust one another, and my advice is just to open, in fact, as much to the professionals. Sometimes the patients also, the people we meet, have been, with reason, have closed a wall because they have been badly received, badly accompanied. Well, there are people who are there with an ability to open and to do things differently. So we can find them if we open ourselves to this. And it takes a great ability to step back and adapt and to trust. That's what I would like to say. Antoine, for myself, working together is a work of openness and humility. I'll go in the same direction as Penelope. There's an old Greek philosopher who said, none amongst us know what we all know together. So first of all, I think as a professional, we need to recognize that we don't know everything and give ourselves time, learn to recognize others and to recognize ourselves and to advance at the speed of confidence. Farron, what do we say to people, either to professionals or even to people who have life experience, so that we can better take care of the others? I'll answer with something that I learned in my role as a peer caretaker, and that is that all perspectives have their reason for being. And it's not a question of choosing one or the other, but to find the balance between the multiple perspectives which are active in our interventions. And for me, that is really something which helped me to find the humility that was necessary to do this type of work. Ghislaine, in one word, before we have to conclude, unfortunately. Humility. I like that. I really appreciate. I'd like to thank you once again to have shared your experiences, your projects. If you would like to know more about the work of Doctors of the World or caretaker communities, I invite you to go to their respective internet sites. There's lots of information, and there's probably also elements that might help you in your own context. For myself, there are a few points that come out of what you said today that I will bring back with me, amongst others, to go towards people, but also to create and build bridges. I think these are two ways to enter into relationship. The strength of dialogue between peers, accompanying peers, such as Farron and Ghislaine, and professionals, of course, but also with the people that we're trying to accompany. I think you well testified to the need to identify and recognize the needs of the people where they are, given their knowledge and their strength also. And also the idea that we need to be open to transform ourselves, to be able to transform the way in which we take care. So I leave the microphone to Tanya, the floor to Tanya, to thank you. But I thank all the four of you for your testimonials and for your time. It's very, very appreciated. So a big thank you to our panelists, Antoine, Ghislaine, Farron, and Penelope, and also, of course, Audrey, for moderating the discussion, for this very concrete discussion on the importance of conscious relationships, the respect of the lived experience and the knowledge of each and all when we take care together. I also would like to thank the great team of Excellence in Health Canada so that this webinar could take place. Also for the learning team and the other members of production and interpreters. Please note that the session has been recorded, and the recording and the list of resources will be sent by email and posted on the website for Excellence in Healthcare Canada. And before leaving, we ask you to respond to the survey on your screen to transmit your comments on this session from today. So thank you for having spent this hour with us, and we look forward to seeing you again. Thank you very much, and a good afternoon to all. Thank you.